Welcome, everybody. Welcome to the sixth episode of the Academy of Osseointegration Hotseat podcast, where we explore the minds of remarkable individuals who have shaped and continue to shape our profession. Today, we are honored to welcome a truly distinguished guest, Dr. Dennis Tarnow. Dr. Tarnow is a distinguished professor of periodontology and implantology at Columbia University School of Dental Medicine in New York City. He brings unparalleled not only expertise, but insight and a wealth of experience toward discussion. With a career marked by innovation, vision, and a deep commitment to advancing both dentistry and academia, Dr. Tarnow has made transformative contributions to patient care as well as education of our future professionals. In this episode, Joe Kahn and I will explore three key topics. Number one is leadership and importance of mentoring and its role in advancing our field, complex treatment planning for single tooth cases in the aesthetic zone, and number three, the future of periodontics and implant dentistry. Lastly, the three of us will recommend books that can be read, or better yet, as audio books in the car and listen while we drive, that will also energize and encourage you to continue expanding your mind. I want to welcome Dr. Tarnow. Dennis, could you share your personal story with us? Tell us about where you're born, where you grew up, and the journey that ultimately led you to your present role of Director of Implant Education at Columbia University.
Well, I wasn't born. I was hatched, according to many people. I was never born. Anyway, I was actually born and raised in Brooklyn, New York. Very poor family, and I was fortunate to have people around me that cared about education. And I basically stayed in New York all of my career. Went to Brooklyn College because it was basically free. It was a city university. Just to give you an idea, we were worried about an increase of tuition from $200 to $225. Shows you how things have changed, tuition. But it was a great education. And then I was fortunate enough to be accepted to NYU Dental School, and then did an internship at Brookdale Hospital. And then I had a special program of two combined prosthetics and periodontics full certificate programs that was designed for me at NYU. So I was very fortunate to meet a couple of great professors. I was asked to do individual to both graduate programs, and the two people, Sidney Silverman, Jack Capsonell, and Sigmund Stahl, basically said, let's try to do a combined thing, perioprosthetics, but a fully trained program in both, and that's what I took. So I have a certificate in both programs, and that's how that materialized, and I really never looked back.
Great, Dennis. I mean, it's great to have you here. Can you tell us the importance of mentoring? And can you provide our listeners any suggestions on how to become successful in your life? And tell us who are one or two of your most important mentors in your career.
Sure. I'd say one of the most important ones was, as I mentioned, Sigmund Stahl. He was the chairman of the periodontal department when I was taking my program. And he taught me how to think biologically. He taught me how to be, he was a mentor in terms of how to think. You know, he would make you understand everything that you were doing, challenge everything. Just don't accept something because somebody had a white coat on and a microphone in front of their face, or was popular or funny. He said, you show me who did it, and show me how they did it. And that's what I've lived by my entire career. So I'd say he was the main academic mentor in terms of what was going on. And I think mentoring is, to me, it's been incredible. It's a second family. You both been involved with teaching, and it's a true second family. You know, when I see you guys at meetings, you're surrounded by your residents, present residents, but former residents. And now I have people all over the world who are teachers themselves, who are renowned teachers in Europe and Asia and South America. And we just really have a bond all together. And it's not about me or any individual, it's about the group. And we even have a chat room with all the former students in it. It's all voluntary, and it's just great. So mentoring is a way to extend your life, in a sense, and the people that you touch personally, not just academically, both ways. And it intertwines, and it's just very special. You both are teachers, mentors, and you know exactly what I mean. Without question, it's the nicest thing. I love my family. It's the nicest thing that I've ever been involved with is teaching. That's why I always insist that my students give back. If they're not full-time teachers in the future, I make sure that they give back at least a half a day to a day a week. I don't know whose feedback that is. Somebody's feedback. I always try to make sure that they give back a half a day to a day a week to teach. That'll keep them fresh.
So it sounds like success in your life is also based on your giving back, is what you're saying, Dennis, which is
Without
very
question.
important. Okay,
Without
good.
question.
Question I got, I know this comes up when I present to residents, and I like to clarify what your opinion is of a short-term study, because you're very much involved with clinical studies, and a long-term study, and what is meaningful for you when it comes to time?
Well, it's obviously a short-term study is obviously 6 months to 2 years. Something which you just see something works. Does it look good? Is it okay? But then you got to look at the minimum of 5 years to really start to see some of the side effects of what you've done and to see the side effects of how the body reacts. I'd say 5 years to me is the proper time. Ideally, we usually say 2 years is minimum, which is true. But at 5 years, you really start to see the differences. I mean, Joe, you've presented so many cases where, 15, 20 years, and I have cases like that. Some of them stay great and others didn't. And the more we push the system and the more we make minor errors in our judgment at the beginning, the more we pay that price over the career of that implant or that treatment plan. And, we can patch it like you're going to see today. We can modify. And a lot of them hold up beautifully, but not all of them are treatable because we made an error or somebody made an error back when the implant was placed. Bad judgment or bad execution. There's two reasons for big failures. Either the lack of knowledge of what to do properly or the inability to execute the proper treatment plan. So you got both. I'll just mention something quickly. What makes a great dentist great? What makes a bad dentist bad? A bad dentist has poor judgment and knowledge and doesn't know how to execute anything properly. They got the wrong treatment plan and they are unable mechanically in the wrong team to execute. An average dentist, which everybody thinks they're above average, we'd like to think that. But the average dentist has one of those two things, not 100%. They either have the lack of 100% knowledge of a given situation, or they don't have the team to execute that treatment plan. They might have the right idea, but they can't execute it. Or they have the wrong idea, or maybe not the best idea treatment plan, but they executed their idea perfectly. And what's the super dentist? Right idea, right knowledge, and the ability with the team to execute the highest level. That's the highest level. I think that gives you a little feeling.
Great. Love it, Dennis. I always think that time is our best teacher. Sometimes it takes our whole lifetime, and still we may not be able to master everything. But share me with your thoughts about epidemics. Okay, such as you look at on-X therapy nowadays is rampant. I want to know your thoughts about that, or maybe when you look at epidemics on periimplantitis. Okay, what is your thoughts on that, and how does that translate to our ability today in maintaining teeth?
Yeah, all on X, as you I'm sure know, Schnittman started all on 3 in 1991. And after I saw that article, I did the all on 4, 5, 6, 7, or 8 in 1997. In fact, the AO gave me the best article of the year for the JOMI that year. It was without question something which was the right way to go for the right case. The problem is it's now become commercialized to the point where people are taking out so many healthy teeth just for the ease and convenience. And when I bring that up to people, they say, well, the patient can't afford it any other way. So what do you mean? This is the negative part. And this is where digital and CAD-CAM come in. They say they can't do a serial extraction case the way we do in our office most of the time. Where we save some teeth, we might keep a fixed temporary on, put implants in between those teeth. And then if we want to then transfer out of the teeth and into the full arch. Certainly there's a place for immediate loading and all on 4. Or all on 6 or whatever, or all on X. But the reality is that people are doing everything for expediency and money. And they're taking away 8, 10 millimeters of bone. And I've been doing this for 50 years. And I've not taken down more than one case like that where I've taken deliberately down that kind of ridge. It doesn't necessarily have to happen. And I finished all the cases I had to with proper treatment planning. That shows you how limited that should be. Very rare cases. But then I go into these DSOs, and they say, well, that's what we do now. And we do it because of finances. The unions, the insurance will cover it. They won't cover prep and temp and crowns, and they won't be able to cover it. But for $15,000 to $25,000 or $30,000, we can do a CAD CAM, put the teeth in, put a temporary on, and some of them call the temporary the final restoration. I've seen that. They call the provisional, teeth in a day, they call that the final restoration. It's obnoxious. It's disgusting. And they say, listen, it doesn't decay. They'll get 5 years maybe out of a good temporary or whatever. And now they can print it out so quickly, they can just make it financially. They can even do it for as little as $18,000, $15,000, which is so cheap. And it's just really just everybody fits the same shoe. Take off all the bone, put 4 implants in, flatten everything. It's just not right for patients. Patients are suffering.
Yeah.
How about periimplantitis? I mean, what are your thoughts on that? I mean,
As you know, I came up in 1993. That's over 25. What is it? Over 30 years ago. 32 years ago, I came up with the hybrid concept on an implant, and I published on it with a prototype in 1993. That's amazing. It took 30 some odd years to catch up. One company, at that time, Rich Lazara made it for me. I don't get any money from the implant or anything, but as I publicized, I didn't patent the idea. But the reality check is that concept works. We knew that the machine top did not create periimplantitis in the same degree that we saw when the rough surfaces came in. We all know that. And so why not have a machine top with the rough and bottom? And periimplantitis came about. We never saw it in the 80s. I saw mucositis, but I never saw so much periimplantitis because I was only doing machined implants at school and in my office. Then we started to see TPS coated implants come in the late 80s and early 90s. And what happened? We started to see periimplantitis. It was really weird. We used to tell the patients at school, listen, we show periimplantitis, we don't handle that. Go back to the dentist and put it in. The periodontist, we don't handle it. Today, it's probably 50% of some practices is handling periimplantitis and its side effects. So things have changed terribly, and it's not a good thing. So
a lot of it is getting rid of the roughened surface to go back to a smooth titanium surface, which is interesting with
not
implants.
so smooth that it can't integrate. The key is the machine surface, not a polished surface. And people confuse the two, and it's different. The RA value is under 0.5.
Correct.
As opposed to machined is about 0.7, 0.6, 0.7, which can integrate, as you know, but it's not so rough that it can't be clean. It can't be cleaned.
Okay, good. All right, Jim, if you could bring up the slides for Dennis, we could get started with that segment. Thank you.
I hope there's no blood in the slides. I get very scared when I see blood. Well, let me start with, I picked a few cases that I think would be exemplary of how to fix problem cases, which is really our main focus academically tonight. And a lot of these cases, I want to give credit for Steve Chu and Adam, our master ceramist in our office, and I just want to give credit for them. They did the cases with me. I did the surgery, Steve did the prosthetics, and Adam did the beautiful ceramics. I want to give them credit. And my great group of partners at SDNY, Specialized Dentistry of New York. They've been a great team for the past 35 years. Anyway, Mary comes in. She had recession there. And this is not a retractor. There's no retractors in her mouth. This is Mary. I couldn't see it at first. Mary came in with a hand in front of her face. And she goes, and I said, why do you have your hand in front of your face? And she was the sweetest young woman. And she said, well, you'll see. I said, well, I can't see. You got your hand in front of your face. So she took away her hand, and this is what she showed. And this is her regular, normal smile. This is not retractors. And she says, I said, well, did you go back to your dentist? She said, I did. He said, it's integrated, and it is, as you see, it's integrated and healthy. She says, you got to live with this. This is the best we can do. Now, he went too far facial, and we all know that that's the bugaboo. Now, this one isn't as bad as some of the other ones I'll show you in a minute. But this one was far enough forward that the tissue receded rather quickly, and she was told she had to live with it. So one of her friends said, come see, Dr. Tarnow, see if he could help you or whatever. And so this is what she did. Let's go to the next slide, please. So what we learned to do, I came up with the idea similar to what Langer did on teeth, decoronation of teeth. He let the tissue grow over. Before we did immediates, he let the tissue grow over to give them extra tissue and blood supply for grafting. Today we don't do that, but the idea worked, because if you take off the top part of the crown, the tissue grows over, as you know, or at least gives you more tissue. So I said, why don't we decoronate the implant? So I said, Steve, why don't we put on a cover screw? It's decoronation. It's the flattest profile we have. I said, let's put on a cover screw and let's see what happens for a couple of weeks. So we did that. Next, please. By the way, and then we put on a cover screw. Now, what's the key to these cases? Can I help? Let's go back one. Sorry. Let's go back. Now, the key to the case, and you're going to see this throughout the next few cases. Can I help this patient when she comes in? Am I capable of helping her? One, there's no periodontal disease on the implant of any significance. She does not have any bone loss. It's all either mucositis or it's recession. So it's not an unhealthy implant. That's a critical thing in the aesthetic zone. I tried to fix both. Don't try and do that. If you're trying to do too many miracles at once, my students know I always say do one miracle at a time. Because if you do too many miracles at the same time, you don't always, you strike out. 3 strikes and you're out. So if you have a periodontal disease on an implant, you got recession like this, and you try and graft and get new bone to grow back, get new soft tissue over that, it just doesn't work. Anyway, the decoronation allows more tissue to grow down over this. And then I can do my graft with more tissue. Otherwise, I got to bring down the mucobuccal.
Hey, Dennis, can I ask you a question? I mean, yes. A lot of times, the clinicians out there inevitably will see recession around implants. Sometimes they encounter that. I mean, and you're telling the audience, okay, in this particular situation, you're going to decoronate and then put cover screw on. May I ask you, can you tell the audience at what stage? Sometimes this type of recession is because of implant position too, right? So where do you draw that line? I mean, because where do you say, okay, I need to take out the implant? I mean, or maybe I should do this procedure. Where does it indicate? Can you tell them?
Great question. I got 2 things going for me. One is that I have no periodontal disease on the implant. In other words, it's not like a bunch of threads that have disease on it. Number 2, it's deep enough to make the turn. It's deep enough to me to match the turn and create a different angle with the abutment and the crown. And 3, here's the key, everybody. Look at the palate. Before I take this tooth off, I looked at what? I said to my assistant, and you're going to see this on all the cases this afternoon, tonight. I said, let me have a mirror. And I look in the palate, not the buccal. The buccal's obvious. I said, let me see the palate. And what do I see? Invariably, most of these cases, 95% of the time, when the midfacial is receded because of improper placement, the palatal tissue is usually good. And that and the papilla are healthy. When I have the papilla and the palate, I can usually fix these cases on a healthy implant.
Dennis, so, I think a key here also is that it happened quickly after the crown went in.
Right.
And it was healthy to begin with.
That's
and there's nothing I could do. I mean, the diagnosis of this issue wasn't even attempted, it seemed like, by the others. So,
however, Bob, a lot of times we also realize that even if the implant sometimes is in the wrong position, but if you submerge, or even with a healing abutment, the recession haven't been expressed yet, So what? Because there's not enough room. But Dennis, I want to go back to your point. At point number 2, you mentioned that if the implant is deep enough, you can turn the corner. Can you tell the audience what is deep enough to you?
Usually a minimum of 3 to 4 millimeters from the height of the zenith point of the adjacent teeth. Minimum, preferably 5. But if you're at least 3 millimeters away, you can usually counteract the change.
So does that mean if you notice the implants were only, let's say, 2 millimeters or 1 millimeter, from the genial zenith?
Not the buccal of this tissue, but the buccal of the adjacent teeth.
Okay.
So that's the key. Not from where you see the arrow, no. What I'm looking at is the palatal tissue and the interproximal papilla are going to be my blood supply. And now I just take it off. Next slide. I take it off, put the cover screw on. Next slide. We put a provisional on out of occlusion. We just bonded without the adjacent teeth. So and look at what happens in 2 weeks. I had to come back ready to do the connective tissue with. And I said, wait a second. Let me see if I can just freshen it up. Maybe you just let it heal. So I said, instead of doing it in 2 weeks, I said, come back and let's give it another few weeks. And 2 months later, look what happened. The tissue continued to grow over. The bonded bridge was not in the way. Next. Now, she was ecstatic here. I could have left her this way. She had the black thing sticking out of her mouth with a hand in front of her face for 8 years. And so now we got this. Now, this is interesting. So this is the decoronation article that we wrote, but it's always very interesting. When you put a cover screw on and you let tissue grow over it, remember we did no flap here. It was exposed to bacteria in the mouth. So it will never close off completely. And people don't quite get that. They figure, well, it's a cover screw, tissue will connect over it. No, that's if you flap over it and cover it over. But if you let it heal by secondary intention, just by letting the opening heal by itself, which is what we did here, you will always find a hole. You just got to look for it. You see the little inflammation there? That's the hole. Next, please. Next, please. So there it is right there. But look at all the extra tissue I got. And I haven't done any surgery yet. Now, this is an unusual case. It just shows what prosthetically you can do without surgery. Now, I was ready to do a connective tissue graft. I said, let's play the game. Now that I got so much tissue, I'll show you, most of the time you have to do a connective tissue graft. But now I got all this extra tissue. Nature's own connective tissue graft without changing the mucogingival junction. Next, please. So then we just opened it up enough for Steve to put on a flat contoured abutment that's flat as could be. So to let the tissue, as you all know, under contouring based on Arnie Weissko's classic article, under contour lets tissue come down, over contour moves tissue up. We don't know that. And it's true on teeth and it's true on implants. Arnie told us that in 1977 and before. And Bob, you've been trained by Arnie. It's a classic article. So I just exposed it enough for the tissue to kind of, be exposed. Next, please.
Hey, Dennis, can you back up real quick? Can we back up? Can you comment to the audience a little bit about your incision design right here?
Yeah, the worst thing, and you're going to see this in all the cases. Thank you, Joe. You notice it's papilla sparing. It's just enough to uncover the implant. Now it's buccal, and that's why you don't put a temporary on. Don't put a full temporary on. Just put on the flattest healing abutment you can find or make. So Kelly does this too. He'll make a custom one that's as flat as can be because you have to under contour. And you don't want to touch the papilla because the papilla are the one thing that is not, not damaged. You don't want to create a possible problem with your papilla. So I don't do, on high smiles, on the interiors, I will do papilla sparing for all of my incisions. And, people talk about, well, you got a scar, all that stuff. That doesn't happen. You might have a groove, but attached gingiva, as you've heard me say many times, Joe, attached gingiva doesn't scar. Mucosa scars. Attached gingiva, you might have a groove. Now, if you push it open and can't close it with a big fat temporary, you're going to wind up having a big space there and a bigger groove. So next, please.
Dennis, one more thing. Since you talk about papilla sparing, how close can you make the incision?
1 millimeter away.
Gingival margin.
Preferably 1.5, but you notice I flared out. You're going to see this in the next cases. I'll flare out as much as I feel I have to cover my grafting membranes and stuff like that. This case, all I was doing was minimal to just expose the top of the implant. Notice that now the reason that there's no scarring is because there's no elastic fibers in attached gingiva. Mucosa and skin have elastic fibers, but gingiva does not. So these are grooves that will remodel over time in 95% of the cases. Look at already here. And 1 year later, you can see the grooves. I didn't do anything to them. And if those grooves bother a patient, we did nothing else except expose this implant. And then now we did some bleaching. Next, please. And Steve just made a custom abutment. Next, please. All ceramic in this case. This was many years ago. And here's the new crown. Now, is it perfect? No, it didn't do any connective tissue graft. This was nature's connective tissue graft, letting it heal over and and notice the verticals are basically, can't even see them. You're sitting on top of the patient's lip looking in. It's not visible at all. Next, please.
Very good point. Can I go back?
Here it is 10 years later. 10 years later, and you can see it held up perfectly even without a connective tissue graft, just nature's own. Yes, I'm sorry.
Yeah, it's fine. Dennis, when you had the abutment placed after you under contoured it, right, what did the patient wear? Because there was no provision.
We had the bonded bridge, which we adjusted. The same bonded bridge that we did when we decarbonated.
Gotcha. Okay.
We just spot etched the adjacent teeth. And
Yeah.
in that case, it was metal. Today, we could use all ceramic.
Yeah. Okay,
But
good.
10 years ago, we got to remember the date when we did this.
And you waited about, what, 4 weeks, 6 weeks or more to
Yeah,
place
now
the
we
separate
usually wait 4 weeks, and that's enough time to give us enough tissue. As you'll see in the next cases, we don't wait 2 weeks anymore. We give it at least 3, if not 4. And
Yeah, I think those are very important points for the restorative dentist in the audience.
Absolutely, absolutely. This just shows without surgery, this just shows what a restorative dentist can do just by knowing decoronation, knowing tissue movement, over contour versus under contour. It's a great case to really teach a restorative dentist how to manipulate tissue. Next, please. And so, what I see single change, it looks like it's doubled up. So what I thought about three more cases to show you and take you up the ladder. That was the most basic one without any surgery, just prosthetic intervention. So next one, I'm going to do what I call the single layer, the double layer, and then the triple layer. Let's go back for 1 second. And so I'm going to take you up the ladder. The single layer is just a connective tissue graft, similar to what Kelly does. Double layer is where I'll do bone graft and resorbable membrane, typical guided bone regeneration. In the triple layer, which is what I find is the most effective for some of these cases, bone graft, absorbable membrane, and the connective tissue graft over the membrane in a special place. And I'll show you what that means by that, a special direction. So
Since you talk about single layer, connective tissue graft, and you quote people like Kelly and so forth, frequently, sometimes when people do the tissue grafting, even the facial bone is somewhat compromised. They use tissue graft to overcompensate. What are your thoughts on that? Sometimes even I see to the extent that even some of the facial bony threads, implant threads are exposed. Will that, if you read some of the articles, they say, if the bone is less than a certain dimension, like 1.5 or so forth, you may promote or increase the risk of periimplantitis. So by doing just tissue graft without bone graft, will that be enough? Or, if we go that track, I'm just curious.
It's a great question, Joe. Here's the situation. You see that in some cases here, I could have done just like Kelly could have done, like the second case, could have done just 2 layers of connective tissue. But I decided to use a bone graft. The problem is the bone, the cases that he'll show, the bone might be receded. You see the threads. But you don't want to touch that connective tissue that's on that implant. It's healthy. That's different than a case where you got periimplantitis and the tissue and the implant's exposed. That's a no-no. That's a totally different ball of wax. But if I have no pocket depth other than recession, like the case I just showed you, then I will leave that tissue there and either graft over it with bone if I don't have enough tissue from the palate, or just bone, or just go for palatal tissue and graft over it, as you see in a couple of these cases. So the next case. But I like to have bone there, but I'm not getting osseointegration unless it's thin. If it's a thin layer of bone, then I can increase the bone and increase the thickness, and that's what I prefer. However, if it's down to the threads and you're looking right at the threads, but you have no pocketing there, leave that tissue alone. Don't interfere with it. It's healthy, and don't interfere with it, and live with it. And integration on the interproximal and palatal should be enough to hold the tooth in. So let's go to the next case, and I think we'll bring that up as we see these cases. Now take a look at Sarah. Sarah's got a couple of problems. She's already had surgery there. You can see the groove on the mesial of the lateral. You can see she's got no real attached tissue. She's going to need surgery. We're going to have to bolster her surgical procedure. We have to do something. So this is rather classic. Again, it's healthy. Now, can I help this patient? She says, this is a smile. There are no retractors in this patient's mouth. These people, they feel terrible. They feel like, recession and the implant's secure. But this is what happened after a few years. It receded way up. Next, please. Now, this is where you get to the point where how far angle, Joe, you asked a great question. How far is the angle where you can't do anything? It depends on the depth, besides the health. And what else is the key? Look at the palatal tissue. Before I took this crown off, I looked at the palatal tissue and saw that the palatal tissue was basically in perfect position. And she's got papilla and a healthy implant. And it's deep enough for us to make a turn. Those are the considerations, all the stuff we just brought up. Now, this one's pretty close to being take it out. Most people would tend to take this one out, rebuild the bone, and put it back in. Let's see what happens. Next, please. Now, look at what the decoronation did. We did a bonded bridge. Look what happens in 4 weeks. Look at that. There's the hole. This one's more visible. See the hole? It always is there because bacteria gets on this. I'm not covering it over surgically, the cover screw, so it's going to have exposed bacteria in the center screw, and it's going to never cover completely, as you see here. It'll just be like a little fistula. Doesn't mean it's abscess, but it's just never, the tissue will never close over completely. But look at my tissue. Now I can make a whole different incision. I can go down at the crest and move it out. And what's the other thing? I can now do papilla-sparing incisions. If I treated the left screen surgically, I'd have to pull down, which is already deficient, the whole mucogingival junction to cover this and graft. Now I have tissue coverage. I'll go to the next slide. And look at my incision, papilla-sparing, and I'm down at the crest. And there's a little hole in my buccal flap, which I'm going to, freshen up and then put the connector tissue underneath it and cover it over. And that's what you see I did here. So she had bone on the front of this implant. It was way to the palate. But I just put the connector tissue graft over it, as you see there, and then sutured it. Next, please. Next, please. And then this is 4 months later. Now, this is the hardest part. This one was so far forward. How do I do a papilla-sparing incision and still allow the grooves that will be created by moving the buccal tissue so far forward? What do I have to do? Steve got the flattest bucket we could find, impression copy, and we put it in, and no crown. Otherwise, the tissue wouldn't close. It barely closes now. And you can see this is what it looks like 3 months later. Okay, next, please. And then Steve did some mucosal blanching, in order to sculpt it as thin as he could be, as flat as he could be. Now, you notice there's a little groove on the mesial. She came in with one to begin with, but it's certainly more accentuated. But she doesn't even see that because she sees the normal, healthy size tooth instead of her tooth with recession. Next, please. Next, please. Now look at the tissue that I got. Now we didn't have angular screw channel abutments then. We didn't have those. Makes a big difference, as you'll see in the next case. But we didn't have them here. So we had to make you can't do this in ceramic. It's got to be metal, because it would break. So it's a gold-plated ceramic metal. And you see, look at the angle that we created. In fact, the whole buccal part of the tube is gone. So this was borderline as to whether or not we could handle this case. But we got it done. Next, please. And this is the before, and this is the after. Now you see the distal groove closed up. You don't see the groove. The mesial groove is still there on the mesial to lateral. Now, if it ever bothers a patient, and it's almost doesn't, if you get this result, they don't see the groove. It's part of the look. And the best you could do is just do a dermoplasty, because it's not a scar. You can do a little dermabrasion with a large diamond stone and flatten it, and that's it, if it bothers a patient. Next,
beautiful result, Dennis.
Next, please. And here's a 5-year post-op. Pre-op.
So, Dennis, great results. A few several questions. Number one, I have on my mind is frequently when you decoronate the implant, remove the provisional or the crown, and then you put a cover screw in it. At times, you see clinicians, they will use a burr to dermabrate remove a layer of the epithelial tissue to promote for tissue, proliferation. I noticed that you do not do that. Is there any benefit of doing those type of procedures at all?
No, it means nothing. Nature will cover over on its own. It's never going to seal off anyway because you got that little fistula is going to form. So it doesn't matter. But you notice the tissue covers over beautifully. You can flesh it if you want. The only thing I freshen.
Yeah, sorry, Dennis. Go ahead.
The only thing I freshen, Joe, is when the little opening, the little fistula, it's now part of my buccal flap. I will just kind of freshen it with a curette a little bit just to make sure it's fresh epithelialized, and then the connective tissue underneath just blends in, and that's all I do. I very rarely even have to suture the opening.
Well, now we're talking about prosthetic material, all right? I'm sure nowadays there'll be more than a few clinicians will have a heart attack right there, seeing you showing, alloy abutments in there. And then because now everybody say, okay, zirconia, otherwise you have all this issue. Can you make a comment on that kind of things? Because you're very experienced. You've seen it all, okay?
I haven't. I don't know about all, but I've seen a lot. Zirconia is not the answer. It's just, people think if it comes out of a computer and it's zirconia, it's perfect. That's a bunch of garbage. You have to scallop the abutment. In this case, you have to scallop the abutment. Make sure the cement is off. Of course, we couldn't do a screw down because we didn't have an angular screw channel abutment at the time. Remember, this was now 10 years ago when we did this case. It's a 5-year recall, but we lost track of the patient. But this is what we are. So what you're seeing here is that if you can, beautiful ceramics and metal can work beautifully. All these cases will be ceramic metal because we were done before CAD/CAM, before we were doing all ceramic crowns, which we do all the time today in the office. It's another alternative. The biology is the key, and the polish is the key, and how good your technician is. And this is Adam doing the custom staining, and Steve with his contour. That's what this is all about. This is not related to making a great dentist. The computer's not going to make you a great dentist. It might make things easier for you or not as easy. But you still got to know whether you're doing ceramic metal like the best, like this, or whether you're doing all ceramic. This one had to be metal post, or if you didn't have an angular screw channel, because it would break otherwise.
Yes, that's the big issue with it, really thinning that anyway if it was zirconia. So
we're worried about this one. Sure, we took it out of occlusion and so on, but you see, it worked out this 5 years. Okay.
I mean, you're at the outer limit of how much thinness you could do on an abutment. I had a similar case, same spot actually.
Right. This was the one that would be borderline, but it was deep enough to still make that just barely make the turn. And we did this with one surgery, just connected to a single layer, pure connective tissue, and we got what we needed.
I think this is a great example, Dennis, is where a team is really needed. A case like this, the materials need to be known by the specialist, and obviously the surgical techniques from the specialist surgeon. So, I mean, beautiful. You couldn't do it by yourself. And you talk about the lab, you can't forget about the lab. So,
not Adam
really working here.
We're nowhere. Adam can match any front tooth to another.
Way to go, Adam.
So two quick questions, Dennis. Number one is when you use this technique, okay, like the 2 cases you show, you are able to, of course, beautifully recover the recession. Have you ever used the technique and then when you put the final, the definitive crown on or provisional, you push it up, and despite how flat you make the emergence profile facially, the tissue still got pushed up. Then how do you handle that?
Yeah, I cry.
And pray.
You don't show the case, Joe. That's all.
Hey, Bob, you got it.
We didn't have much time, but have I seen that happen? Of course I have, but thank goodness it's pretty rare. The reason is, as you're going to see in the next case, and particularly in the AAA graft, what we've seen is that by putting the connective tissue in the right place, it's not just putting connective tissue in. But I'm going to show you in the third case, the triple layer case, placing the connective tissue has been the key to now not seeing that often, Joe. People just put it on the buckle, like I did here. But it's really about the buckle and the incisal part. It's got to be, and I'll show you that when I show you the suturing, it's got to be over the occlusal surface as well as the buckle. And that's the key. And since I've been doing that with the triple layer graft, as you'll see, as you know, then we don't see that problem because we're thickening the tissue for the restorative dentist right where he or she needs it. And that's right at that gingival margin that you're looking at right there. Not just on the facial, but occlusal and facial. Great question.
So one more point.
Yeah, sure.
So far, all the cases I've seen from you raise a flap, and I'm sure to a lot of modern clinicians, they will freak out. I mean, so tell me. I mean, a lot of people, they'll be tunneling, all kinds of things. So you raise flap consistently. Tell me what's the story on that, and what's your opinion on that?
The big thing, I love access. I was brought up with access, and I see it at school. I see this being done all the time with tunneling and everything. And I've done tunnels, of course I've done tunnels. But I find that to do the kind of bone grafting that I'm looking for, bone and soft tissue, I need better access. And I want the ability to manipulate the buccal flap where I want it in an easier way without fancy sutures that have to be pulled down just to avoid what? What are you avoiding?
Yeah.
Avoiding the vertical. And that's why these people are so hesitant. And some of them make the vertical distally and distal the canine. I've seen that. And they incorporate 3 or 4 more teeth. I'm incorporating 1 tooth, and that's it. And you can flare out. Tony Sklar in his book 20 years ago showed how to make these, and Odette Bahat showed the same thing, how to create in the journal, how to create plastic surgical procedures to advance flaps. And we still do that today. Odette's article from 25 years ago is still the standard. Next week, I think the next case will help us. When we come back to it, Joe. Excuse. So then let's take a look at double layer. Here's just regular GBR. Let's go to the next slide. And we'll put it all together with the third case. Now this is a very interesting case. Alicia comes in. She had an implant that was placed on the lateral. She's got recession on the central. Now why does she have recession on the central? Because that flap was opened up, and it tried to manipulate it a few times with different grafting, and it didn't work. Now she has height of the central, but the implant is too far mesial and it's too far forward. Next, please. So the implant is healthy. Okay, it's deep enough, just barely enough. Now I have height, but I also have recession on the central. So tooth alignment and contour. Now this just shows you even that the crown contour is not correct. Look at the zenith points. Look at that big depression right over the lateral. Besides the natural recession on the central, natural manipulation of that tissue. So she got gingival recession number 9, facial depression, and discoloration of number 10. Now, next please. So look at that big depression she's got there, and look at the buccal bone when we did the CAT scan. This is where there was none, see? So this is exactly what we were talking about earlier, Joe. This is the kind of case where they're so thin. What do we do there? Next, please. Now, I had Steve get that crown off and make it temporary. So you can see how far forward this implant was. Okay, plus you got the big depression. They put it where the bone was, but there wasn't any buccal plate. Now, there was no pocket depth here.
Yes.
No,
it's an important point to share that there's periodontal health other than the position.
Exactly. Exactly. Next, please. Now, just with that alone, now look at the incision that I made. I'm going to do. You want to tunnel this? You have a good time. I'm trying to have a bone graft and soft tissue recession on a tooth at the same time. I want access. I want manipulation of the tissue, and I don't want to disturb the papilla in any way that I have to. So what I did here was I go inches. Look at the incision. I go short of the papilla, leave it basically alone. Same thing with the central, the mesial of the central. And then you do the classic coronally position flap where that sharp point where the dotted line is going to be pulled down and cover the midfacial in doing so. Now, we know that from the research that coronally position flap with the connective tissue graft is by far the most predictable and best coverage percentage and longest lasting. I mean, it doesn't mean you can't do it with alloderm or anything else, but the best research, the most valuable data shows that the percentages are higher when you do connective tissue. So I'm going to do that. But look at the buccal of number 10. 10's got a big depression. I see that metal. And there was no pocketing again. So I'm trying to leave that little bit of tissue alone. Next, please.
It's partial thickness. So it's a very good point to share. Yeah.
But take a look at that. Look at that whole buccal. Look at that left slide. Look at that slide on the left. You see the whole plate is gone, which we saw on the x-ray. Yep. I'm going to release the flap. And this is the critical part that most younger clinicians don't get. You have to release the flap completely. So it's passive closure. No pulling on the flap. You go up into the periosteum, release the flap, and that's the key. Then I clean the root with different instruments, clean the root to get coronally position, flatten it a little bit, as you see right here. Next, please. And what am I going to do? I did 2 different graftings in the same case, right next to each other. I did a connective tissue graft and sutured it to the papilla that I plastied to the central. But the buccal and the bone loss was so great, and the big depression on the lateral, I did a guided bone regeneration. Now I didn't really want the bone to integrate. There was no pocketing there, but I left that tissue covering that implant. It was still good tissue, and I'm using this really as a filler. So here I use the BioOz collagen as a filler, plump it out, something that won't go away easily, and then put a membrane over it to give me some guided bone and contain it and do guided bone regeneration. And then I'm going to coronally position over both. So I did 2 different things, connective tissue graft and GBR on the lateral. Next, please. I had height there. And I do a single incision on the palate. Marcus Hertzler's textbook has a beautiful example of how to do this for those of you who are not used to it. He's got a great book that's showing this. I use the Hertzler technique. And I see people doing all these sutures, around the top. It takes them 20 minutes to suture, around the buccal and then proximally and matches sutures. Not necessary. It's a bunch of hooey. You want to do it, go ahead and do it. It's a waste of time. I'm too busy to waste my time if it's not better. This is easier, better, and less painful for the patient afterwards. These patients have almost zero pain. They're a little sore, but nothing major. Really amazing. instead of leaving the whole palate exposed for the first week or two.
Since we're talking about this, sorry, go ahead, Bob.
Is this chromic cut? It's resorbable, but what is
Yep.
it?
Chromic cut. I use chromic for 98% of my suturing.
It's not like
not plain, but chromic cut. 5-0 chromic cut, the most common one that I use. That's good.
So since we're on this topic about fancy suturing, I'm just curious. I mean, actually, for both of you are more experienced. Okay, how important, in your opinion, is it to use? A lot of clinicians are use high magnification microscopes and all kinds of things. Does it really? Is it a game changer? I'm just curious.
I don't think. Well, I use magnification, but not a microscope. So I use loops, and so that's enough magnification for me. And I got results, as you see, and it seems to give me all the.
What level of magnification do you use, Dennis?
I think it's 2x, 2.5 or 3.
May I ask, Bob, what magnification level do you use, Bob, when you do surgery?
Depends, but it's usually 2.5. Going up to 4.5, but it's hard to work multiple cases in a row.
For me, is 2.0 or 2.5 too.
Well, I'm the same way. I have both 2.5 and 2.0. I got 2 sets. So you see, it's pretty simple. You notice there's no tension on the flap. It's not like I'm pulling it down. I got total release, and that's the key. And since I've been doing that for the past 20 years, flaps stay where I put them, and they don't easily, pull back because I released the flap so well in passive closure. So now I sutured down to the plastic papilla. The papilla's still under there. Next, please.
Yeah, one of the many keys is that passive release, Dennis.
That is the anytime you're coronally positioning or you're putting a graft in and you want to cover it, that's the way to go.
Yeah.
So here's the temporary still in. Steve made a great temporary, realigned it a little bit, and we plumped it out. I got coverage on the central, not 100%, but probably 90, 95. Next, please. Next, please. And here you see the central looks great. There's the cut. Look at the tissue I got on the buckle. Could you maybe have done more? But take a look. That's what I got. If he wants, then Steve's going to go and finish the case. Next. Steve and Adam. So there's the final crown in place, as you see here. And next, please. And take a look at the bone graft. So here I put in something just for space. So you see before and after, and before and after. So look at the left slide. That's really the key. You can see the bone graft particles. It's really as a filler. Do I expect bone to be regenerated on the buckle? No. I had left tissue there. It's not going to. I didn't touch it because I don't want to interfere with the healthy tissue that was there. So what you see here is the buckle. Look at that second picture over. That's all graft material that filled up the void aesthetically, and then the contour did the rest. Okay. Did we lose Joe?
Yeah, I'll be back, I'm sure.
Okay.
Quick question, Dennis, regarding the post-op all the way to the far right. The reason why your prosthodontist, I guess it was Dr. Chu, used the shorter abutment versus the longer abutment that was originally in there.
Give us more room to do the contouring that we wanted. That contour, look at the distal, look at the mesial. It's tilted too far to the adjacent tooth.
Yeah.
And that was eroding the papilla. Good question.
Yeah.
Next
All
week.
right, beautiful case. I think the value of contour augmentation cannot be underestimated because of results like this.
So we did a combination of things here: connective tissue, coronal tissue flap, bone graft with GBR, 2 separate things. Notice I had height here. This one I had height on the lateral. I had a big depression, so that's the reason I chose this.
But going back to what Joe's comment was the minimally invasive. You hear this all the time.
Right.
I mean, to try to do this minimally invasive would be next to impossible. So it took probably 1/3 the time. You had the access. You got the coverage. Obviously, you got the great results, and you're onto your next patient, which is good.
You don't see any vertical scars, that people call it. You don't see not scars, they're grooves, but you don't see them because they're not there. They blended in, and so they're not always there. Sometimes they will be, sometimes not. Joe, how are you? We missed you.
Yeah.
Well, you should have heard us talking about you, Joe.
I have no doubt. Yeah.
We love you. Now, so you notice that you don't see verticals here. Look at where they made those incisions. They're not even visible. Because when the patient sees the result of the proper contour, the rest is easy. And Steve's job and Adam's job are easy. If you give a restorative dentist tissue contour that's normal, there's no masking. If you can do this, you're not asking them to use pink porcelain and shading properly. That has to be done in some cases. And, it's a separate lecture. But in cases like this, where I can offer tissue that's relatively normal contour, not perfect, but close. This is what it's all about. And that way they can do beautiful restorative dentistry and everybody looks good.
Dennis, there's a question. In this case, did you place the bone graft over the periosteum?
That's exactly what we did in a sense. It was really a filler. It's really just a filler. It means nothing. I don't want to interfere with whatever tissue was healthy on top of the threads. And there was no pocket depth, and that's the key. No, I don't have the cases here. We had limited time tonight, but I have cases where I went in, there was a buccal defect. Where there was probable, that's different. And I have to do titanium brushes, detoxify, all the things we try. And then I had to wind up grafting on top of that. That's different. That's if I had a pocket there with a diseased surface on the buccal. These were not diseased. This was no probable depth.
That's beautiful.
Hey, Dennis, when you do the grafting, the barrier you use, resolvable barrier,
Right.
how important it is to use fixation, such as tags or suturing, how important that is?
I'm going to show that in the next slide, what I do to control the movement when I think it's critical. I'm going to show it in this. This is why this is the ultimate layer, the triple layer graft. And I'll show you how I handle that. I don't use tags. I'm going to have them in my office if I use them. But I'm using Gore-Tex for big ridge augmentations. I'll do tags. But really, really rarely. I don't like going back after them. And I don't find them necessary, except for major Gore-Tex kind of cases or, with titanium reinforced, Gore-Tex, cytoplast. These cases I don't find necessary, and you'll see why. I use the palate as my guide. The palate becomes my key, as you can see that in the next case. So let's go to the next case. Now look at this man. So I'm going up the ladder. That's her smile. There's no retractors in that girl's mouth. And in fact, they were twins, and they both went to the same dentist. They're both in their 20s. They went to the same dentist, and he put the implants in exactly the same way. It was almost identical. But take a look, and they said, can I fix this patient? Well, this one's hard. You got a big depression. How deep are the implants? They're just barely deep enough to make the correction. But they are healthy. But look at that big depression on the buccal. Congenitally missing laterals. That's why there's a big depression there. And he put the implant in, and the good news, the implants were still healthy. But she wouldn't let him finish because whatever he put in didn't look good. How can you look good with a smile like that? Everything was masked. Everything looked disgusting. She says, no way, you're not putting that in. And she, after 3 years or 2 years, she just said, I've had enough. Let me get another opinion. So that's when she got sent over by another patient. So we looked at her. And so next, I look at the palate. There is some tissue on the palate. And the papillae are healthy. Those are the good things. And the implant's healthy. There's your three. Next, please. This is the case you don't want to treat. You send it to your friend that you don't like, down the block. This one's a tough case. And it's bilateral. It's a tough case. And a very demanding patient. She's a beautiful young woman. She and her sister are beautiful. They're young, they're in their 20s. And the whole world's in front of them, and they look like this. So they were really upset, okay? And the bonded bridge isn't enough either, because the bonded bridge, you still have the big depression there. You're on a high smile line, so you got to build up the ridge either way, and your implants are in the way. So what I do, I decoronated. Steve took them off and put a cover screw on. Next, please. And look what difference. So we took them off, and look at the tissue. See how it's grown over? Same thing. But see the little redness? You know what that is now, right? There's a little hole there because the tissue cannot cover it completely. When you just let tissue go over a cover screw, it's dirty, and it will never completely allow you to close over by nature. But now I can make a different incision again. The more forward the implant is, the more I can make it slightly to the crest and not use that same spot. Next, please. So there's the opening. Look at that. But notice I got some extra tissue there. Look at the thickness. Next, please. Now look at my incision. This is very important, Joe. This is exactly what you were asking before. My incision is at the crest and papilla sparing at least 1 millimeter away from the adjacent tooth. And then I'll flare out to the buccal. I could have even made it flat more if I wanted to, but this was enough. I'll flare out to the facial and allow myself to, and I'll open up the palate a bit in order to, as you'll see, secure my membranes and stuff. But this is going to give me the ability to, is that you? I don't know what that is. Okay. So I open the flap, the hole in the middle. Next, please. And now, see, this implant had bone, but it was still totally depressed. Look at the big concavity on the right screen where my elevator is. You can see that huge concavity. So what am I going to do here? I don't have enough connective tissue from the palate to do both of these cases and do connective tissue to fill up the void. If I had tons of it, I could, but she wouldn't have a palate left. So, but in this case, I used the bone to fill up the big void of the depression. Next, please. Release the flap. That's what we discussed. Automatic. I do that before I make my graft because I want to not have to do this later. I do so much so that I want to be able to pull that to the palate and go 3 to 5 millimeters past the crest. Next, please. Now, what does this bone graft do? It's filling up the void, see? And then I'm going to do GBR on the buccal just to give me more thickness of bone. Now, she's got a healthy implant, but I don't want to fill this in more aesthetics and combination of maybe building up the buccal plate. So I'm going to put that in, and here's a resorbable membrane that I'll put in, and I'll be able to, and I have it positioned so I'll be able to tuck it onto the palate. Next, please. Now, here's the key. This goes back to the previous case and what I was trying to mention to you guys before, what I was emphasizing. Where I put this connective tissue graft, a good piece of connective tissue I got from the palate, I'm positioning it not on the facial. If I want to do more on the facial up high, I'll just put more bone graft in. I don't need it on the facial. What Steve and I have learned is whenever I do this and put the connective tissue at the crest, over the whole crest, that is where he needs his thickest tissue to manipulate the tissue and the crown and not get the future recession that Joe, you and I have both seen. And this is what it's stopping. So, and I do one suture through the membrane. That's a 4-0 chromic suture through the membrane. What you're looking at there is I go through the membrane and the connective tissue graft together and tuck it under the palate. Prevent it from moving. And that stabilizes my entire piece. I don't use any tacks. Everybody understand what I did here? So I positioned it, I tucked it onto the palatal flap, take one 4-0 chromic suture with an FS2 needle, go right through them both, and then come out the palate and put a single suture in. That's it. Next, please.
You know, Dennis, when you make a papilla-sparing incision, such as situations like that, especially afterwards you do coronal advanced flap movement. Frequently, the flap that you reflected as you suture, it overlay the non-reflected part, the proximal part tissue. You understand? Just like, for example, you get back of your side, you know what I'm talking about. So under such circumstances, do you advocate de-epithelializing that adjacent tissue, or you just suture to it and it doesn't matter?
This is a good case to show that. See, I just tuck it in and around the edges and then suture it. So I know exactly what you mean. It's like too much tissue because the V shape, I want good closure. The V shape, when it comes down, will have extra tissue around. So I find that you can still push it around and manipulate it and still get yourself covered the way I have here. At 5-0 chromic, I got one 4-0 right to hold the palate. Then I got 5-0 chromics to just close these verticals, and that's it. And so the key is that I've gotten the mid-facial built up. There's the right and left side. Just remember, she got both going on. There's the right side and left side. So there's two different ones. Next, please. Next, please. And here it is healed after. This was 6 months later. Then we did a small exposure, and notice where the implants are coming out. Now, to sculpt the tissue, you don't do cementable temporaries. You do it with, and Joe will verify this. You do it with a screw down that you can push the tissue around, and this is the critical piece. And even though it's a pain in the neck, there's the screw holes coming out the buckle, and you have to close it with composite or some acrylic each time. This is the way to manipulate the tissue without any cement.
You'll never fully seat it with the cement anyway. So,
yep. Well, there's no cement here. There's no cement.
No, but I mean, if it was cement, you can't possibly fully seat it.
Well,
and
yeah, to scallop the abutment, as you'll see in a minute. This is before angular screw channels. We didn't have angular screw channels. Today we can do the angular screw channel. It would be a piece of cake. Next, please. Next, please. So look at the beautiful tissue. She had big depressions there. And by the way, look where the verticals. You can still see little remnants of them, but she's ecstatic. She's seeing normal tissue for the first time, normal contour. And so look at the shape of the tissue on the left. the higher tissue, but we got built out buccally. We've got that extra thick tissue that Steve was able to manipulate with that thick connective tissue graft. Next, please. And here's the scallop. Here's the key. You scallop, we gold plated it, but we scallop the ceramic metal abutment. It's going to have a cemented crown, and this is now going to re-angle the prep in terms of cementability. And this is how we did this case. The scallop is the key, so it's not too deep, and we get the cement off. Next, please. And here's the final crown on the left side. Notice a nice contour. Next, please.
The facial profile is beautiful.
All right, here's the one on the right side. Not 100%, but pretty damn good. Looks great. I'm happy. And by the way, where are the verticals? Oh, the verticals, the patient's going to die. It's going to go crazy. They don't go crazy because you give them the contour that they need. Let's say not to do it with other ways. You want to do it with a tunnel? Go right ahead. Spend an extra hour on the case. Whatever you want. That's up to you guys, okay?
Then it's maximally invasive, yes.
Yeah, actually, it's one tooth. You're not talking about opening a whole jaw, Next, please. And here's the right side. Okay, next, please. And this is the before. Remember what we started with. Big depression, metal showing, high smile line, the toughest kind of case, recession and buccal depression. Next, please. And there's the before and after.
Beautiful.
And how does this hold up? Next, please. Take a look. There's the after. And how does this hold up? We'll disconnect with Joe, like you were saying. Do you see the recession? This is a case that we would normally be worried about. But by putting the connective tissue on the crest, not just on the labia. Next. Here's 7 years later.
Beautiful.
Incredible. Hey, Dennis, comment a little bit about your CTG. I mean, as a friend, I respect your work, you know that, but I just want to comment a little bit. Sometimes nowadays I see clinicians, they do a lot of deperforized FGG, just a nice piece of tissue. And I saw you just slap that piece of tissue there. I mean, sorry, don't feel offended. Just with some fatty tissues around.
Right.
Is this still working, or what's your thought on that?
How's it look?
It looks great. I just want your thoughts on that. How important it is
I'll tell you
to
exactly
make
what
that
my thoughts
looking piece of tissue,
I'll tell you exactly what my thoughts are. When I have a nice thick piece of tissue and I need it, I don't thin it out and start touching it. And don't worry about the little fatty glands and all that. You want to know why? Because they have a blood supply already there, and the little capillaries around, whether they be little fatty tissue or whether they be connective tissue, it's already got a given blood supply, and the reanastomosis takes place and life goes on. The more I interfere with that blood supply and trim it, the more I have to reestablish blood supply. So when I have a piece of tissue that can lie in properly and I can use it, and that's like you said, the slab, I love it. Like the Garvey used to call it, give me a piece of meat. Garvey used to say, he used to, I want a piece of meat up there, and he's right. And that's what happened. He and his team, Team Atlantic, they would do a big piece of meat, and that's what I did there. I don't want to trim it back. And I don't worry about a few glandular tissues and cells. Just look, well, the proof is right here. And I've been doing it this way for the past 20 years, and it doesn't seem to bother anybody.
Dennis, 2 quick questions based from
But you understand why, though, Joe? Because the blood supply has not been. The more I interfere with that graft after I get it out of the palate, the more I'm interfering with the normal capillaries that are in there, including around the fat type cells or whatever. Okay, that's why I don't want to interfere. This way, the tissue collapses and the flap goes against it. It can be anastomosed with the vessels right at the corner.
Yep. Regarding that second case where you left that tissue, so there's some healthy connective tissue on the facial. Say if when you end up dissecting it, you expose it, you got threads exposed. There was a comment there. What about, is there a concern? How do you handle that? Because
there was no pocketing. I would do a split flap there. I would not have elevated off.
But say that you did a full thickness, you didn't realize it was exposed.
I would leave it that way. I did a full thickness and I see the threads are exposed, but there was no pocketing. I wouldn't touch it again. I put either connective tissue or bone graft over it for the day. In other words, I don't take some more arduous photos. What you do is start shredding it and doing anything to that, unless they do to that threads exposed. If there was no probing depth, the better off they'll be. Leave it alone.
The second question.
Cover up with another one.
If that same implant with really bad angulation facially is too shallow, How do you make that decision? Because I always say I want to have my team help make that decision if it's not treatable. Okay.
If it's only two, you notice these by decarnation, I got 3 to 5 millimeters of extra tissue.
But if it's too shallow,
though, you have to take it out. Otherwise, you got to do a ridge lap.
And generally, what would you do if you took it out? Would you graft it then? That's one of the questions. What do you do if you have to take that?
It depends on the palatal bone and how big the tissue is. But I would back them out. Today, I'll use thin diamond if I have to use a diamond. But today, we do all the reverse torque. We didn't have those before, 8 years ago. But we used to trephine them. That's the worst thing you could do. Today, if the buckle was dehisced, I would do maybe a little bit on the mesial and distal with a very thin, like the 859 surgical diamond that I use to take teeth out by Brasseler. I go in and make a little opening, pry it forward, and it's out. But first thing I do is always try to talk it out. No question about it.
Joe, you want to ask the last question since we still have Dennis awake in Florida there?
Sure. I mean, I have so many questions. I mean, Dennis,
you let me go to sleep.
I want to know something about dual zone, Dennis. I mean, first of all, dual zone. How did you, first of all, come up with this idea about dual zone? How did it come about?
They don't have the slides. I remember I put this in the group. You didn't give that to them, did you?
No, we decided against. But why don't you just discuss it? Because
sure. I have the case that I put the case in with the 13-year post-op on it. What I did was one of the first times I put an immediate in, like 15 years ago. I put it in, and there was a gap. So I put some bone graft in. We didn't put temporaries on. It was a perfect case, nice thick tissue. I put the implant in to the palate. There was a gap. So I had some, bone graft. I used some, small particle cancellous bone. I packed it in and everywhere. I had some extra bone. So I wasn't going to flap it. I wasn't going to cover it. So I wanted to let nature heal by its own by secondary indention. I knew enough then not to pull the flap over. It's central incised. So I just filled it up to the top and got initial clotting right at the chair. In 10 minutes, you get a clot, like any other clot. And I let the patient walk out that way, just like as if it was just a clot with an implant in the center and with a healing above. And I said, okay, come back, and we watched her. I have pictures of it every 2 weeks, and eventually it just closed over. Now, the key is, I did this case with Dr. Brown, one of my partners. And she then sculpted the tissue because the tissue, of course, didn't have a temporary or custom abutment. So the tissue on the central closed over around the abutment. So she had to sculpt it, right? With the screw down, she sculpted with the temporary. And after she sculpted it beautifully. And she said, then come in, take a look. I looked at it. I looked at the buccal pregingiva inside the sulcus, sulcular tissue. And I saw what appeared like a white sheet there, like a little white something. It was the bone graft thickened, it stayed in there, and it thickened. This without a temporary holding it in, even just a clot. And then when she sculpted the tissue, you could see it on the sulcular part of the free gingiva. And I realized that it had thickened the tissue beautifully. It's without a connective tissue graft. And that was it. I never had to look back. The only difference is what graft material we use. We don't want to use bioos supercrystalline or cortical bone because it doesn't go away. The small particle cancellous bone is ideal. It thickens below the crest, and it thickens the free gingiva. And we don't see infections. We don't see irritation. 1 in 100 maybe get a little irritated. But with the bioos, we saw the pieces on thin scallop tissue. We saw the pieces work their way out buccally. It became an irritant. But we didn't see that when we used a small particle like Puros or cancellous mineralized bone. So that's what we used. That combined with the temporary, Paul Weigel in Germany called it socket shield. Not socket shield, socket seal with the temporary provisional sealing. And that's what we do. And we do with a custom abutment or perfectly with the temporary. And then it just lies in there. We give it 4 months to heal, and we take off the temporary, and we can see the gorgeous tissue response. And we even see bleeding. And we published on this because we get the epithelium. Many people don't realize this. You get the epithelium to adhere to the acrylic. And that's great. That's our best tissue, is when we do that.
Dennis, thank you so much for your insight and obviously your experience in sharing these beautiful cases. Jim, if we can go to the last slide of the book selections. There we go. Dennis, you had recommended that From Strength to Strength, Die with Zero, Joe, right. Good to Great, and Do No Harm. You guys want to just briefly talk about those books as recommendations?
Well, I put down two of them, from strength to strength, and on the bottom, and die with zero. The die with zero always gets people up nervous because they figure you're not going to have any money when you die. But die with zero is a different thing. It also means investing into experiences throughout your life, even if it didn't accumulate money as you might think is best. Having a life experience with friends and so on was more important than just making money and having money in the bank. That was what Die with Zero was really all about. Life experiences makes you a better person, and you'll make more money because of it, because you're more interesting and better off. And strength to strength is interesting. There's a curve in all of our lives, depending on our age. You're going up, you're growing, you're getting well known, and then you reach a plateau. That's your greatest point, whatever that is. It could be at 40, it could be at 50, it could be at 60. But then you're usually not as good after that. You might plateau if you, with rare exceptions, do you go further up. It might happen, and we like to think we always get better, but otherwise, whether it be because of medical, emotional, or not emotional, medical, or memory, or whatever, you start minding up going downhill. Now, the going great to great is you get a new curve, and choose something that will give you a new curve and be able to work with. And I think that you go great to great. It's sort of like two curves and they intersect, and the second one then takes over your second part of your life. And that should be something that makes you happy. You've hopefully made enough money to be secure and do the things that make you happy, whether it be philanthropy, taking care of things that you never did because you were always working too hard. Yes. And it becomes a different kind of reality. And that's what that is. And the other part of it, don't be afraid to try something new at a different age. It means that you've never done before, especially a sport. Especially a sport, because you didn't do at the age of 25, because then you'll never be able to compare what you would have been like at 25. If it's a new experience at 65, you will now be able to say you only get better because it's so new to you.
I truly believe God created pickleball. So, Joe, you want to comment?
Yeah, Bob. I mean, the two books, interestingly enough, both books are actually recommended to me by, some pretty known dentists. Okay, one is actually Odette Bahat is the one who introduced me to a book of Do No Harm. I found it a very interesting read. It's about a surgeon, brain surgeon specifically. Okay, going through what he went through in his career. Doing brain surgeries and all dealing with human lives and so forth. The bottom line is, I think as dentists, we can apply to us a lot. There's so much stress what we do, but we must really view each patient as a special individual, not like a little meat market here. Okay, you talk about sometimes those all on X situations. So we need to treat everybody special, and of course, as clinicians, there's no way that we will not make mistakes. That's life. We can have complications, we can have failures too. But the philosophy is try our best to minimize the damage, because when we treat patients with respect, that should be able to minimize the damage. Okay, and then good to great actually given to me by another friend of mine. He's a wonderful prosthodontist, Sri Koka. I don't know whether you know him or not. Okay, but Sri gave me the book after a lecture in Italy one time, and it is a great read. Okay, talk about how to you look at different companies, how do they, what clicks them to become a great company. It is not easy to be good, but to be great is very difficult, and to sustain even harder. And that also applied to me a lot, that when I try to do my clinical work, as both of you know, is not easy. Dentistry, especially aesthetic dentistry, is extremely challenging and demanding. So, sometimes looking at some of those factors that you'll find on the book, it can give me some ideas, okay, how to create that sustainability, how to, hopefully we can achieve greatness. Great read. Try it.
Yeah. Thank you both for sharing tonight with me. This has been an exciting night, and
thanks for your hard work putting this together, Rob.
You're very welcome. Your wisdom. And I'd like to just advertise our next speaker, Irina Saylor. There she is, a friend for many years. And it's on Wednesday, June 4th. And it'll be streamed live from Europe. And it'll be at our lunchtime East Coast. It'll be 12 to 1 East Coast. So I want to say thank you, the guys in the back room, Jim and Will. Thank you so much for your help through AO. And Dennis, terrific. And Joe, as always, my friend.
An honor. Thank you guys for being with you.
See you all soon. See you next time. Thank you.